Welcome everyone. Today we'll be starting the first of many with YINU talks. This is planned as having a podcast along with a video session in which we will be interviewing our consultants and also having relevant talks which will help not only urologists as consultants but urologists in training. And these will be small topics but very relevant topics. So today's topic for the day is PHEOCHROMOCYTOMA. And as we know that the rule of 10 which was being used earlier for PHEOCHROMOCYTOMA is not applicable anymore. And it is a diagnostic conundrum at times because the patient comes to you, he has elevated BP, he's on multiple antihypertensive drugs, but we don't really know how to proceed with this. And we have here today with us Dr. Altaf Khan, who is a professor in Department of Urology, Yenepoya, Dr. Mujeeburahiman, the head of Department of Urology, Yenepoya, and we have with us from the endocrine field, that is Dr. Sowrabha ma'am. She is a leading consultant endocrinologist in Yenepoya and in Mangalore, and we have a consultant anesthesiologist, Dr. Thippeswamy sir. Welcome. So this will be like a small case presentation in which you will be taking a certain patient. This is all based on patients that have been admitted with us initially, and we have evaluated them, and yes, we have operated them, but somewhere along the line we have made a few errors or mistakes and we have learned from that. So as in like any institution, it's always a teaching experience. So that's why we wanted to address these problems that are there so that we get a better path to follow. So coming to the case, it was a 51-year-old male, a known hypertensive on 3 antihypertensive drugs, came with the incidental finding on ultrasound of a 3 centimeter adrenal or suprarenal mass, and his blood pressures even with the 3 antihypertensives was not on control. So I'll first go to the urologists and then come to you, ma'am. How would you all proceed with this case initially? Dr. Mujeeb sir?
We'll have to, this is basically it's a multidisciplinary approach. We'll have what in my mind is a few. So we'll immediately include the endocrinologist plus the cardiologist in this case. Then basically with the radiological imaging, we'll be doing the ultrasound, and CT is compulsory, and we'll come to a diagnosis.
So like sir said, we do a CT scan, we do an ultrasound. On a CT, it is diagnosed as an adenoma, and you come to a diagnosis of a PHEOCHROMOCYTOMA. So ma'am, how do we proceed where this is concerned? This is just radiological. So in biochemical, how do we diagnose that it's a PHEOCHROMOCYTOMA, and how do we exclude the other adrenal masses that are there?
Right. So in a case with resistant hypertension in a middle-aged person where PHEOs are strongly suspected, in such a patient with a high pre-test probability, we call, the plasma metanephrines would be better than urine. Slightly, it will have a better diagnostic value. Although 24-hour urine metanephrine, normetanephrine levels are also almost equally sensitive and specific, we would prefer, and for the convenience of it, do a plasma fractionated metanephrine and normetanephrine level in this case.
Okay. So what about urine vanillin mandelic acid? So when it's a 24-hour urine test that has to be done, and also the normetanephrines and metanephrines that are being sent, it comes within 1 or 2 weeks. So do you do it on an OPD basis, or will you prefer that the patient is hospitalized so that we can monitor him better? What would you take from there?
Yeah, so the VMA, that is the terminal metabolite.
Yes.
So these metanephrine, normetanephrines are the intermediate metabolites. So what has been found is the VMA has a very low sensitivity and specificity compared to metanephrine, normetanephrine. So that is totally out of the guidelines, latest guidelines now. So when we send the metanephrines plasma or urine, it is usually outsourced. It is not done in many labs. So it is usually run about once or twice a week. So it depends on when the sample reaches the lab. So it takes some days for that. But that is the test that we would go for.
And so whether to hospitalize him or do it on an OPD, and also there are a few requirements that the patient has to follow before the blood test is drawn. So can you elaborate on that?
Yeah. Madam, I have a doubt in this case because plasma metanephrines, fractionated metanephrines and normetanephrines, if you take, is there a specific time, like episodic? In adults, what we have seen is an episodic headache or episodic release of the hormone. So plasma, at what time you prefer? 24, there is no controversy on that. But right. Plasma metanephrines, if you take, is there a specific time? Because usually in this area, it has to go to a central lab, and because they do it on a specific day and time, because the samples also will be less. So can you just enlighten us on regarding the 24 hours or plasma metanephrines and normetanephrine?
Right. So when it's plasma metanephrine and normetanephrine, we already have a high suspicion in this case. Yes. And we must remember that the metanephrine, normetanephrine are all the time present in the blood if it is a PHEO. So the catecholamines, that is the norepinephrine and epinephrine, are episodically produced. Of course, some produce it continuously, some tumors, it is unpredictable, but the metabolites are round the clock supposed to be present. So it is okay to, although earlier people used to believe that 24-hour will pick it up even if it's episodic production. Now plasma, anytime it can be taken, but preferably, as we discussed, patient should be hospitalized because patient needs to be supine for at least 15-20 minutes. Ideally 30 minutes before the sample is drawn, and any other drugs like anesthetic agents, of course pre-op it's unlikely, antidepressants, even the latest SSRIs can affect the levels, any anxiety, certain things which can push up the catecholamines, some foods like banana, chocolate, patient has to be stop taking it for about 3 to 5 days, and then patient has the sample has to be given. But generally these foods don't interfere when it is significantly high, but the posture matters. But 24-hour, of course, the urine collection should be adequate. We must send 24-hour urine creatinine level so that ensures the collection is adequate. Suppose we take it from 8 to 8. So in the morning 8, we ask the patient to void out. So whatever urine was collected was of the previous 24 hours. And then after that, the patient starts collecting the urine in the can. And then next morning at 8 a.m., the patient should void in. And after, so it's like the correct 24 hours is required to get the cutoffs.
So,
like you have told, the patient should be supine and you have to give all the instructions. Would you like to collect the blood sample yourself, or you would like to instruct some staff to take it? And one more thing, any antihypertensives need to be stopped, like beta blockers or any other alpha blockers, to be stopped before taking the collection?
Yes. So one thing is, if we give clear instruction that a patient has to be supine for 15-20 minutes, it's fine. Or if a junior doctor or a resident is present, it's all the more better. But there is no... Yes. Yeah, we should ensure that the patient is supine. So there is no recommendation as such that any antihypertensives are to be stopped. But certain synthesis inhibitors may be, but we generally don't stop. We continue it as the patient is taking.
Thippeswamy sir, since the patient is admitted, now that we are suspecting a PHEOCHROMOCYTOMA and we have started evaluation, you know that he might go in for a operative surgery. I mean, he'll go in for surgery or something. Anything from the anesthetist side that should be done for the patient prior to surgery?
That's a good question. So generally what will happen is, many a times, because we have a good endocrinologist and urologist, so it is better to see the patient immediately when it get admitted, so that we can evaluate the patient better. And for me, the pre-anesthetic evaluation requires how well the patient is controlled from the day he is admitted to how well he is controlled. And for me, pre-anesthetic goals mainly requires 2 to 3 things, like how well the BP is controlled, whether he has any end organ damage, so for example cardiac conditions or any other things, and third thing is how bad other systems are involved. So if that is okay, then we are ready to go. So that is the main thing. So if at least one time we see and evaluate, then we can evaluate just one day prior and then we can plan.
On another note, we have PHEOCHROMOCYTOMA. Now, what if this was a younger age person who has a PHEOCHROMOCYTOMA? Do we need to evaluate for men's syndrome, or do we need to go where that is concerned? Or even if it's an elderly male of 51 years old, maybe not diagnosed initially with having men's syndrome, do we go for that? Or do we each patient check for his clinical features and then plan for a men's syndrome evaluation or a genetic testing basically?
Right. The suspicion in a case who is younger, and if there's a family history of suggestive of men, of course the suspicion would be higher. But like you just mentioned at the beginning, the rule of 10 or the 10% rule does not hold good. So it's no longer like 10% is familial.
Yes.
Up to 40% can be familial. At least there can be genetic variants, whether it is germline or somatic. So it's preferable to at least do a genetic testing, not just of the patient's blood, but also of the tumor, is what they say now. So because the incidence is much higher, but in a younger patient, of course. But the thing is, in any syndromic patient, say for example, they have a medullary carcinoma thyroid along with the PHEO, the first tumor that has to be addressed is the PHEO. Yes. So that is, as it is, the first one that has to be tackled.
So we have started the treatment for this patient and we have started on the drugs. So what is the preferable drug that you would prefer for this patient, and how long will you treat him, and when can we take up this patient?
Right. So as it was from the 1980s, it is always the alpha blockade that has to be started off. So although guidelines say phenoxybenzamin, we prefer shorter acting and selective alpha blockers because of the fear of post-op hypotension. So prazosin is a very commonly used drug. Doxazocin is also in the recommendations, but we prefer one of these, that is prazosin, say. So we start it off about at least 2 weeks prior. They may need longer alpha followed by beta blocker if they have cardiac involvement, but at least 2 weeks prior. So we start off an alpha blockade, and after say 3 days, we have to start the patient on high salt diet. At least 5 gram of salt patient needs to take every day. So a rough estimate is like 1 teaspoon is 5 gram of salt. So 5 gram of sodium patient should have. So around 12.5 gram of sodium chloride. So 2 teaspoons. Okay. So through the day. So we ask them to measure it out. We actually check that every day patient is consuming that salt. That is again to tackle the volume contraction so that post-op we can prevent the hypotension. So after minimum of 3 days of alpha blockade, we start high salt diet and add a beta blocker to target the heart rate.
So this is on the 3rd day itself we'll start a beta blocker.
After complete alpha blockade.
So is there any criteria like the Roisen's criteria in which we can judge whether adequate alpha blockade is there? Do you use it on a regular basis or?
Yeah. We actually have a target BP of 130/80. Okay. Of course, round the clock it's difficult. There will be some variations, and a standing BP should be at least above 90. We prefer. Although Roizen says 80/45. Yeah, at least systolic above 90. That is as per the guidelines we follow, and then we start checking the heart rate if there is tachycardia. So supine 60 to 70, 70 to 80 on standing. That is, we do follow it.
So we have started this on the 3rd day itself.
Yes.
And now we have achieved our goals by the 7th day. Will you take it up or will you still wait till 2 weeks are complete?
At least 1 week, they say. So something around 7 to 10 days, preferably 10 days. Right. It is preferable. So
some places do take it up at 5 days. There are pros and cons to that also. But you, like you said, you take it up at 7 to 10 days. Any particular reason why we do that?
So the complete alpha blockade and the beta action is supposed to take that long. So we need that much of alpha blockade for the adequate BP control. So that is what is told.
Now in this case, the patient is already on 3 antihypertensives, and if one of them was an alpha blocker and if the BP was well under control, how will you go about? Like you have to wait for again some days, or you can just go ahead?
If the parameter, we are 100% sure patient has been on the alpha blocker and
No,
the
he is not on alpha blocker. He is on some other
On the
calcium
drug.
channel blockers, but his BP is
It's
under control.
It's not
No,
resistant. It
no.
is a normal. I mean, baseline is also 130, 120. He's on three antihypertensives. Do we still need to follow the criteria of going
yes,
till 7
definitely.
days?
Alpha blockade is a must. Is a must. There are some studies coming that calcium channel blocker can be used primarily, but still there is more robust data awaited for that. So alpha blockade
If
is a
any patient
must.
on AC inhibitors with thiazides and calcium channel blockers, still you got to.
Yes, we have to do alpha blockade. Yes.
Say if I take up the patient in 5 days, what are you expecting that can go wrong?
Yeah, so arrhythmias can happen, hypertensive crisis can happen.
Yeah, for Thippeswamy.
And this sodium, normally for a hypertensive patient, they are a little reluctant to take the sodium. So 5 gram or 12.5 gram of sodium chloride every day, will it affect the BP control?
So in practice, when we are already giving the patient alpha blocker and after 3 days we start off this high salt diet, it usually does not affect. Of course, patients are resistant because they have been always told that for hypertension you should not take. So when we explain to them, it is fine. So for the hypotension, actually it definitely helps if we give them extra salt.
Okay. So now 2 weeks are over. We have finished 2 weeks. We have optimized the patient. We're planning to post. It's 14 days are over from 1st of November or so. 15th we're planning to take the patient. On the day of the procedure, the patient has a high BP, that is almost 190 plus. Do we still take up the patient, Dr. Thippeswamy sir?
No, if one episode of BP is high, so actually we give him a rest or you take one or more readings, because what happens is suddenly you go there and you have taken one reading, so suddenly you can't take a decision on one BP reading. So that is one thing. And if there is if sufficient evidence that you have attained a good alpha blockade, so there is no need to postpone. And in the anesthesia guidelines also preoperatively what they are telling, so if emergently you have to take even even 5 days of just alpha blockade with prazosin, you can take up the cases. See, for me, anesthetic management, there are so many PHEOCHROMOCYTOMAs we come across. Some may be very much aggressive, some may be lighter. Okay, they may not be so aggressive and some might have a end organ damage, where the good alpha blockade with beta blocker and good control of BP is very much essential for the post-op outcome of the patient. Whereas if an young patient comes with no comorbidity comes, intraoperatively with the available newer drugs what we use in anesthesia and a very good monitoring system, we can still tide over the crisis and we can come out with a good outcome. So if you take in 1980s, where the death rate of PHEOCHROMOCYTOMA surgeries was almost more than 80%, recently there's published that there is no death from the PHEOCHROMOCYTOMA surgery at all, almost in all over India. Okay, so that is how we go.
We've started on alpha blockers. We follow the Roizen's criteria, or is there any particular time when we can start the beta blockers? And what are the beta blockers that we start with? Because you had mentioned the alpha blockers. Any particular beta blocker that we can use?
Yeah, after at least 3 days of full alpha blockade, after it is achieved, then we start the beta blocker.
So achieved
That is,
as per Roizen's criteria.
Yes,
Okay.
yes. So the blood pressure supine 130/80 and standing, at least the systolic should be more than 90. We take for practical purposes. 80/45 is mentioned, and the heart rate to control, we start off monitoring with the beta blocker. So non-selective beta blockers like propranolol can be used, but they have to be used more times a day, like propranolol 2 to 3 times. Or metoprolol can be used, that is the selective atenolol or metoprolol we use generally.
And
So-
what dosage or what BP again with the beta blockers do you want to keep? Because we've achieved the alpha blockade, so BP is already on a lower threshold. So with beta blockers, there might be a risk of going into hypotension. So and CCF. So how do we titre it and how do we go ahead with that?
Yeah, so the increase should be gradual. Usually the BP reduction will not be that much with the beta blocker what we have observed. So usually the starting dose in practice what we have seen is starting dose or maximum say 50 mg of metoprolol twice a day. We are able, that is high actually, 25 mg XL, metoprolol XL twice a day. We are able to achieve the heart rate control and an adequate, so at least the supine blood pressure more than 110 would be ideal. It's not mentioned as such, but that is good enough. And then again the standing should be above 90 and the heart rate we target.
But even with, say there are two scenarios. One is a resistant case, like even after giving alpha blockers, your Roisen's criteria is not achieved even after 2 weeks. And we've started beta blockers, but it's not reaching that level. So is there anything else that we can do for that?
Yeah, so a calcium channel blocker are a good option actually. So along with that, sometimes we add nifedipine or nicardipine we can add, like sustained release nifedipine is commonly used now. We can add that. So that helps many times. Okay. But in malignant PHEO and some cases, like they say catecholamine blockers, but preferably it is not used, like if in inoperable cases we use it, metarocin, but then I have not had to use that. With calcium channel blocker we are able to almost achieve it because that causes profuse hypotension post-op. So, and sometimes if there's an emergency, of course, parenteral.
So back to the where anesthesia is concerned, where if you're taking up the patient prior to, we're taking up the patient and prior to that he develops hypertension, like I mentioned, and even your second and third reading is still high. Are there any indications in which you will postpone this case, reevaluate him and then take him up?
Yeah, many things we take into consideration about how he has gone water retention, or what you can say that is hydration also. Then orthostatic hypotension you take. Only BP reading you can still omit. And it also depends upon the urgency of the surgery also. See, for example, if it's coming for elective surgery, so you can take it and give 1 or 2 days of extra. And why its BP is coming? Because it was all the way normal. Yes. And for me, more important will be his ECG changes, whether he has and any added arrhythmia is added or not. If just BP readings are little variation, like 160/90 we take it. If it goes to 170/80 or 190/80, you give him little good anxiolysis and again see whether it is BP is maintaining. Many a times the anxiety itself will have a very high BP. That is more important. And the beta blockade, I don't know, because our books also says, I have to ask madam also additionally, like is it beta blockade every time it is necessary? Because they are telling with drugs like prazosin and doxazosin, which do not have a tachycardia itself as a side effect, which was very classical of phenoxybenzamine. So should we add a beta blocker in all cases, or if still, if BP is good, heart rate is 60 to 80, can we take up? So
yeah.
Usually,
unlike the alpha blockade, which is mandatory, beta blocker is not mandatory. As long as the heart rate is achieved, maybe with a calcium channel blocker, or it does not go so high, it is fine actually. It is not required. Absolutely.
So as far as we understand is 2 weeks a patient is admitted. In a standard case, you are giving alpha blockade. You control for 3 days at least, you observe, then you start the beta blockade. And saline, salt, you increase the salt from 2 weeks onwards, or after the BP is 3 days of alpha blockade. Then fluid, preoperatively, intravascular volume has to be increased. Then how will you give and when? Suppose 2 weeks back, suppose the patient is posted for a surgery, say on Wednesday. So will you start it on Monday, 48 hours prior to that?
And you had mentioned the term hydration. So whether to overload or load or just hydrate.
No, this is hydration is because the moment they put it in a high salt diet, they usually consume the water because it itself will take. So that is enough. And what happens is, because we are giving a alpha blockade already, so that will have a little vasodilation. That itself will have a water retention problem. And second thing is, we have to measure the serial hematocrits. So what they tell is, preoperatively, it's ideal to decrease your hematocrit by 12 to 15%. That indicates that there is a good hydration of the patient. So that we take. That is the reason, that is what indication of good hydration is.
Any clinical parameters like pitting edema or something you like to see whether they are overhydrated or underhydrated? Nothing.
Generally,
And what is the general rule? How much of the fluid? Because if it is oral intake, he has to increase, or IV fluid has to be given. So approximately 2 liters extra, because he is a hypertensive patient. So we are little worried to give the fluid. So if the intravascular volume is the concern, what is the fluid to be given? Either it's oral or parenteral. And when will you ask them to start?
So when pre-op itself, when we tell them about high salt, we also tell them to consume enough fluid. There is at least 2 liters of extra fluid.
Extra fluid, ma'am, 2 liters per day or 4
Actually,
liters
it
per
is
day, or how?
There is maybe up to 2 to 3 liters. There is no exact cutoff like that, but ad libitum, as much as they want. They are supposed to be freely using fluid. Only thing, if they have some cardiac issues, then it can be a problem. So, and 24 hours prior is usually we start the...
Many of our urology patients are already CKD patients and have another comorbidity of an ischemic heart disease. In those cases, patients, how will you exactly load them or hydrate them? And will it be oral or IV?
Yeah, so if as it is we are supposed to restrict fluid, so usually a little less than the urine output we say. So we follow the same thing, but orally it is not so much of a problem. But one day prior when we give say 2.5 liters, when we give IV saline, then we may have to give a little less. So as it is generally followed, we may have to give a little less.
We'll
But
have to watch out
for
breathlessness or
yeah,
anything things
basal
like that.
crepitations and fluid overload situations.
So,
and to add on that, what happens is phenoxybenzamine when we are using, that had a longer half-life. So what we were worried is the moment the tumor is out, the intravascular, what happens, that is adrenergic crisis, what was happening, like suddenly there is a depletion. So phenoxybenzamine would have not washed out well. So a patient would have an exaggerated hypotension. With the newer drug, what we are using, prazosin and doxazocin, so that is very much limited. So generally we are not much feared of the hypotension per se. And as many a times, the patient's cardiac status becomes a very important measure for hydration rather than the routine guidelines. Okay, so it varies between patient to patient depending upon the cardiac status and the renal status. And since we are going with prazosin and doxazocin, which are very short of life, because hardly it takes 6 hours for prazosin and 12 hours for doxazocin, so we need not have to worry about the hypotension.
would you
part.
recommend the patient is going to be 12 hours NPO, or do we follow ERAS criteria? And if the patient is NPO for 12 hours, do we start a maintenance fluid? Because and at what, how many fluids do we start? Do we start a ringer lactate or a NS?
Yeah, now we have a balanced salt solution for all patients.
Okay.
So we start a balanced salt solution around 50 to 80 ml per hour because it's an NPO status.
Yes.
And now that with ERAS, we don't keep NPO even for the clear fluids, we allow till 2 hours of the surgeries. So around 100. So 6 hours for that only we can start with that.
So
Coming to stopping of the drugs. So we generally give pre-medication with 1 day prior, we give a good dose of anxiolytic drugs. The metoclopramide should be completely avoided. So we either go with Rantac or pantoprazole for the antacid prophylaxis. Then good anxiolysis. We give prazosin, you can continue till the morning of the surgery, whereas doxazocin we give in the previous night. So that is the extra guidelines with the routine guidelines what we follow for the any other case.
So adequate oral hydration. You don't need to give too many IV fluids or so. In conclusion, we can give almost 2.2 to 2.5 on a minimum basis per day. Since the patient is admitted and since he's on a high salt diet, he'll have that desire to actually have more water. And prior to the surgery, I think 12 hours before the surgery, we can hydrate him with an IV fluid. And like you said, sir, we can continue the antihypertensive drugs, that is prazosin, till the morning of the surgery. And we can hydrate him till we shift him into the operative theatre. Anything, sir, you would like to add?
No. That means that whatever antihypertensive, it has to be continued.
Yes. So we have taken this patient into the operative theatre. What would you as an anesthetist want to secure prior to a surgery?
Okay, anesthetic goals per se in management of PHEOCHROMOCYTOMA carries especially two things. One is to avoid the surgical stress. So whenever there is a handling of the tumor or anything, it's not only about the handling, it's a surgical stress and the tumor handling, there will be a hyper secretion. So to handle or to decrease the BP during that time. And second thing is when the tumor is removed, like if the patient goes for an exaggerated hypotension, to combat that. That is the main anesthetic goal in a PHEOCHROMOCYTOMA, apart from managing effective pain management and good depth of anesthesia. So in this preoperative evaluation, as we have discussed, preoperative evaluation becomes very important, and the anesthetic management and the lines what we secure depends entirely on the cardiac status of the patient. Say for example, recently we did one patient who had a pulmonary hypertension and almost very cardiac status, like poor ejection fraction. So if the patient has a poor cardiac status, we have to secure all the lines, including invasive BP line. So we have to have a central line, 2 wide bore cannulas with real-time monitoring of either transesophageal echocardiography, or we can have a Swan-Ganz catheter or pulmonary artery measurement with the continuous cardiac output monitoring. But this Swan-Ganz catheter, that is a invasive, too much invasive. So we try to reserve it only for the selected set of patients. Routinely, we can go away with the intra-arterial BP monitoring, that is invasive BP monitoring, and the 2 wide bore cannula and central line with a good depth of anesthesia.
Is there a change in the drugs that you will be giving the patient for induction and maintenance, and how will that play on the BP in this case of pheochromocytoma?
Yes, induction and maintenance varies according to the, especially for this case, according to the patient base, as I told. So induction, we additionally give, we also keep a very short-acting beta blocker like esmolol to tide over the BP. We have a NTG, we have boluses of sodium nitroprusside also we keep. So routinely we induce with additional doses of fentanyl, that is opioid, which has a little stress response, it will decrease, okay. So with routine induction of propofol, and we avoid the drugs which have a histamine release. We avoid the drugs which have anaphylactic things and which sensitizes the heart to the adrenergic stimulus. So we avoid all those anesthetic drugs. So we have now propofol, and with little bit of hetomodate in a cardiac patients, we use a vecurinum, which is a drug of choice, and we use sevoflurane, isoflurane, and we use a Tiva also additionally to control the BP. That is what the induction meant. And usually we secure the invasive line before the induction. This is the one case where we take an invasive line, keep a continuous BP before induction also. So just enter the patient into the OT, we take a lines, and we routinely bit to bit variation we were able to do, and we induce the patient on that basis. So that is how we do, and the expert usually will take over even the airway manipulation also, and intubation will be done by the expert anesthetist, so that we avoid the stress during that. That is the induction phase. After that, positioning, and the next comes when there is a pneumoinsufflation. So that time also it is very transient, and we use the, again, short bouts of NTG or SNP or depth of anesthesia by increasing the propofol, dexmedetomidine. The magnesium is very good drug, and all this with esmolol. So any of the drugs based on the BP. So we try to contour and try to keep it between the 120/80 to 160/90, which is good for the surgical response. We go with the MAP, and but before that, if you maintained well of SBP, DBP, so that is also okay. It doesn't make much. One value doesn't make any difference with. What we go is pulse pressure variations with the volume status, and the ECG changes anything stress ECG changes we are getting or not, and the regular BP, like we were able to maintain the SPP but DBP.
Coming to the approach for the surgery, what approach would you all prefer, Dr. Altaf?
Yeah, since this adrenal is a retroperitoneal tumor and it is very deep-seated, so a laparoscopic approach is always better. Apart from the advantages of laparoscopic surgery like small incision and less operative pain and less bleeding, since the tumor handling, as Dr. Thippeswamy told, that once you handle the tumor, there is shoot up of BP. So with the laparoscopy, we can directly go and access the vessels, mainly the adrenal veins. We can just go and clip it. So laparoscopy approach is best in case of it is small tumor. If it is large tumor or if you are thinking of malignancy and all, definitely we can go for open. But if it is small tumor less than 7-8 centimeter also, we can go for a laparoscopic approach. And now that we have robotic, that is one of the best approaches we can have without any fluctuation in BP. We can directly go on to the vein and clip it. Then once the vein is clipped, then we need not worry about anything. We can just go ahead.
As Dr. Altaf mentioned, pre-operatively a good discussion should be there in these kind of cases. You should have a discussion with the endocrinologist, with the anesthetist and the radiology, because malignancy, the approach depends on the whether it's benign or malignant. Malignancy only by the looking at the radiology, because there is no other indicator. Even the dopa PET or whatever PET is there preoperatively, there's whether the lesion, even in the malignant PHEO, if you debulk the tumor also, the drug, whatever the drug antihypertensive, you can reduce it. So you should have a good understanding of the radiology, whether it is malignant. See the look at the tumor, whether it is a regular tumor, whether it is irregular margin, whether there is an infiltration, whether there is a necrosis, those kind of things, the size of the tumor, and there are other areas where the metastasis. In those kind of things, open it and do it. Suppose there is a organ confined and use it as a PHEO, if it is the operable, pre-operatively good discussion with the radiologist, then come to that. You can go either by laparoscopy or robotic, which are minimally invasive. Easy, go there and clip the vein first, so that there is a crisis is not happening. So it's in the words, good understanding of the anatomy of the lesion, and whether it's a benign with hormonal excess or whether it's a malignant lesion. Whether you are preoperatively you are able to go with a minimally invasive. Minimally invasive is the best.
You should discuss it with the radiologist, and if the patient has come to you, always ask for a CD so that you yourself can study the case and go ahead with what approach you want to do, because not always minimally invasive is the best, where you have to study it, you have to discuss it. If you're in an institution, take the help of your other departments and then plan the approach for your surgery. So what is the critical step in handling a PHEOCHROMOCYTOMA intraoperatively?
Yeah, intraoperatively, left side is easy. It all depends on the size of the tumor. Left side is easy. You can clip because it just vertically joins the left renal vein. On the right side, it is a posteromedial in the IVC. There are multiple small veins. It's only one, not one vein. So clip it nicely so that there is no intraoperative. Vein first, then the artery, because it's a very vascular organ. Artery next, the first vein. But ulta, if it is the kidney, if you clip the renal vein first, it will profusely bleed. But here, because the concern is to control the this. Once you handle the tumor, there will be excess of release of the catecholamines into the bloodstream. So the crisis can happen. So clip the vein. That is the. It's all the dynamics with your team.
Yes.
That is very important, and it should be a good preoperative discussion with the team who are all participating. It is very important.
So, Thippeswamy sir, so when the vein has been clipped and we are going to touch the adrenal, what would you be watching out for exactly?
Yeah, again, the surgical field you can divide it into the pre-tumor ligation and after the tumor ligation. So, initial dissection may find like little bit bouts of paroxysmal increases in the BP, which can be managed very well with the anesthetic drugs, like what we have a routine antihypertensives, short-acting antihypertensives we can manage. And usually the surgeons convey like before their dissection is done and they're about to clip the vein. So they'll usually convey, and ideally we require 10 to 15 minutes before prior to tell that we are going to adrenal vein and we are supposed to, because that is to prepare myself with the volume overload, because the moment they clip there is a severe hypotension which usually responds with a good hydration, and I should also have a vasopressus with standby. So usually we keep all the induction agents with that. We keep the antihypertensive infusions ready, and we also keep the vasopressus ready attached with the central line. So the moment the patient, the surgeon clips, and if there is an hypotension, we load. That is why wide bore cannula we keep. We load fluids and colloids if needed, and then we have the vasopressus if the BP is not coming up. So the surgeon's explanation, any anesthetist, two anesthetist will be there inside the OT and watching, especially this is one surgery where you have to watch the screen and the surgeon also and the patient also very much.
Okay. We have now shifted the patient out. ICU is mandatory for such a patient. And with an hourly BP monitoring, vitals monitoring, any role of hydrocortisone that comes into this patient, and what is the dosage and when do you start it?
Yeah, as per guidelines, there is no specific role for hydrocortisone in this case, because although one adrenal may be removed, or it's a totally a medullary tumor, not a cortical tumor. So unlike in a case of adrenocortical carcinoma where multiple hormones can be produced from the tumor, that is the cortical hormones, here usually we don't expect that the tumor was producing cortisol, which in turn suppress the production of cortisol from the other adrenal. So that is the fear generally when there is a adrenalectomy that is happening. So there is no as such indication for hydrocortisone, unless we may have to, for other indications we may have to
There is
go.
no indication, but a few cases that we have suspected a PHEOCHROMOCYTOMA, we have gone in for hydrocortisone. I think 3 days we had given it at 50 mg once a day. So does that help, or?
Actually, if pre-op evaluation for an adrenal tumor, when we do a overnight dexamethasone suppression test and then there is no suppression, like if it is still high, that means some cortisol production from the adrenal tumor. Co-secretion with the medullary tumor is not well known, but if that happens, then maybe we can, for the benefit of doubt, we can give a hydrocortisone. There is.
So the patient has been shifted back and into the ICU. What are the parameters that you will be observing for the next 48 to 72 hours? What is the fluid that you will be giving and at what rate, and how will you be titering it? And the third question is that what are the antihypertensive drugs that you will be managing the patient with?
Yeah, once the surgery is done, so the extubation becomes a very important thing. Even extubation criteria are there. If the patient is poor cardiac status, as we told, like cardiomyopathy already there, and BP is not coming up with the usual vasopressors, or it's not maintaining well, so we try to keep in the ICU without extubation for at least 24 hours. Then we plan extubation. And in these cases, post-op analgesia also becomes a very, very important for the good extubation. Okay. So many a times what we have seen, at least in our, from the experience what we had, we never ended up, like we didn't have much scenario where we were not able to bring the BP up, or we were not able to get the BP in the normotensive range. Okay. So once preoperative BP is seen, we have seen the patients, ideally for the renal perfusion or the vital organ perfusion, we require a BP of at least a MAP of 80. So we keep the MAP 80 as a target, and we try to keep the MAP 80. And coming to the fluid management, nowadays we have what is called as goal-directed therapy and hematocrit CVP based. So goal-directed therapy is where we continuously measure the pulse pressure variation or the systolic pressure variation. We keep within the range, like within the 12, that is a good goal-directed therapy. And the other thing what we have to see is serial measurement of blood sugars, because that is also very important in these patients where sugars fluctuations are high, and electrolyte balance. Because we are using a plasma lights in these patients, so the electrolyte disturbance is also less. Okay, and if there is no intraoperative bleeding and the surgery went very well, so you don't require a blood transfusion, you don't require a colloid transfusions, you just require a good balanced salt solutions in 100 to 120 ml per hour. You can take it initially we give a little high based on the urine output and assess to the goal directed therapy, then we slightly taper. And with lap robotic surgeries, the patients are ambulated very early, and the patients can be taken orally very early. So that is a good mode for the starting of the hydration. And coming to the post-op complications, we have either an hypertension or we may have a hypotension. Hypotension is because of what we regularly think or what we expect because of the tumor removal until the other adrenal takes over. Because of the suppression of HP axis, it takes some time to recover. That usually responds to the fluids, or nowadays we recommend noradrenaline followed by vasopressin. Vasopressin is independent of the what regular norepinephrine acts, like metanephrine acts. So adrenaline independent of that action. So vasopressin is preferred if noradrenaline is not acting, and that hypotension can be taken out. Hypertension becomes a headache because we have removed the tumor thinking that it was a PHEO which was causing an hypertension response. So we have to reevaluate whether the tumor resection was not adequate, whether we have missed any the inadvertent, the surgical causes has to be ruled out for the residual hypertension. If surgical causes are not there, then we actually start up with the antihypertensives. If antihypertensive infusion started, so slowly when he starts on orally, then we'll shift him to orally. And coming to labetalol is not the preferred drug, especially to control in PHEOCHROMOCYTOMA, because it also has a alpha plus beta action. So we don't prefer labetalol as such as a drug. So we either go for cardioselective drugs or the other drugs.
So will NTG infusion help?
Yeah, if the BP is above 160/90 or above 180/110, definitely NTG infusion is given. NTG is a selective venodilator, and previously we were very happy with the sodium nitroprusside. And sodium nitroprusside, the problem is with the toxicity. So we have to keep on measuring the toxicity. So, but it is a very potent drug. So usually if it doesn't control with the NTG and esmolol infusion, then we go with the sodium nitroprusside.
Altaf sir, what are we looking at the patient in these 48 hours to 72 hours as urologists? What will we be looking at?
See, we'll be looking at the patient's parameters like blood pressure and stability of pulse rate, blood pressure, Then usually we don't keep a drain for adrenalectomy. Earlier we used to place a drain to see for any bleeding, but nowadays we don't keep a drain. So we'll be just seeing his abdomen is soft and any other thing is. If everything is maintained, we usually discharge the patient within 2-3 days. The patient is back home working.
And like sir said, will you be ambulating the patient early
Yes,
or how soon?
We will be next day. Actually, if it is done in the early morning, by evening we can ambulate the patient. Or else, usually by next day the patient is ambulated and we start him orally. The same day night we start on oral liquids and next day we start on full diet.
So does bowel sounds or passage of flatus, does it play
definitely
a role?
we have to see all that abdomen because we have done a laparoscopic surgery. Sometimes there can be some paralytic ileus or something like that. If once he has, bowel sounds are there and if he has past flatus, we start diet quickly.
Anything you would like to add, sir?
Yeah, nothing.
Sir?
It should be patient-centered. Patient should go home with minimal drugs, early resumption of their work, a multidisciplinary approach, preoperative, intraoperative and post-op.
Okay. And the last few questions. Sowrabha ma'am, how will you follow up this patient? Like after the surgery, any biochemical parameters you would like to reassess? Would you like to get another plasma metanephrines or things like that? And how often do you follow him up?
Yeah, so whatever metanephrine metabolite, like whether it was the metanephrine or normetanephrine, whichever was elevated, if both, then post-op we have to do both. So pre-op, if we had chosen the plasma, post-op we do the same thing. If we had done the urine, post-op we do it. Okay. So perioperatively, the stress can cause some variation in the values. So at least after a week, like 1 week post-surgery is preferred. Not exact time is not there, but usually at least after 1 week of the procedure we do the metabolites, because normetanephrine sometimes are the only ones which are elevated. So if we have a choice pre-op to do one, normetanephrine is more sensitive, so it is preferred. So if only that is elevated, post-op will be doing that.
What about imaging, Mujeeb sir? When the patient comes back, unfortunately, the BP is still not maintained. After he's been discharged, it was throughout the procedure, post-op, it was fine. Now he comes back with another hypertensive crisis. He's again having hypertension. Would you suspect anything? Would you like to get any tests done?
No, what I would like to see the histopathology of that. Preoperative biochemical evaluation, histochemistry, histopathology report, and still the other things and all like paragangliomas may be there or residual tissue may be there. So the PET is required. It all depends on the biochemical as well as the radiological imaging and clinical evaluation of the patient in the postoperative setting, whether any other repeat evaluation is required. It will be depending on the histopathology as well as the clinical parameters.
All right. any investigation or any test that you would like to get done prior to surgery, one day prior to surgery, or from the anesthesia side?
Yeah, we will be taking the serum electrolytes, then the blood sugar monitoring, apart from the routine metanophenol what we have done. And we also take the ECG and echo provided one day before we try to repeat it, just to see that there is no additional things. Because we would have seen the patient 2 weeks back and we would have given a good drugs. So just to see that the patient's effort or whatever of efforts are good, so we take up and it becomes a medical documentation also for the purpose of the management. That is in addition to the routine evaluation like what we do for the any other case.
So, in conclusion, some take-home message from you, Thippeswamy sir?
Yeah, as you said, the PHEOCHROMOCYTOMA surgery management is a team approach. So everybody is important and everybody's presence and active participation is very important. So in this, starting from the beginning, when the patient comes, a good preoperative evaluation, good BP control, and then the good anesthetic management, the minimal YINU surgery are the good one with the surgery outcome, and the post-op management. All these things, if team approach is done, the patient definitely will have a good outcome.
And what about you?
Yeah, so irrespective of whether the blood pressure is high or we are not suspecting so strongly, but if there is an iota of doubt, it's better to do an alpha blockade and follow the conventional approach. So potentially we say it's a time bomb ticking inside. Yes. So we deal with every case that way. So that would be my message.
Altaf sir?
Yeah, as we all know, like perioperative management is perioperative management is one of the key factor in managing this PHEOCs. So if you have imaged properly, we have got all the investigations done, metanophenol's and other stuff, and we have managed the BP well, then there should not be any, we should not foresee any complications or any problems post-operative.
So in conclusion, PHEOCHROMOCYTOMA, though it is a diagnostic conundrum, is a difficult case to manage. If you have a multidisciplinary approach to it, if you discuss the case prior to starting it, if the patient is admitted with you, in an institution you have all your departments present, you can always discuss this case and then come with a strategy or a plan to evaluate the patient, manage it, and then take it up for surgery. So that is very important, and you have to always communicate with your colleagues as to what and where we can improve after your surgery. Each case is something new, and I hope that today's YINU talks helped, and we will be having future talks about different topics where this is concerned. So I'd like to thank our guests for today. Thank you very much.
Thank you.
Thank you very much.